Okay, acute kidney injury and chronic kidney disease. This is chapter 28. In this chapter, we'll talk about renal failure, both acute and chronic. We'll discuss uremia, which is one of the consequences you will see, and then look at different we'll look at cardiovascular consequences as well as other consequences. So, renal failure. This is a condition in which the kidneys fail to do its job, and its job is to remove metabolic and waste products from the blood, to regulate your body fluids, your electrolytes, pH balance, all of those things that we talked about in the previous chapter when we talked about what the normal functions of the kidneys are. So, when the kidneys fail, for example, to remove waste from the blood, then the waste is going to remain in the blood. And so what we're going to see is nitrogenous compounds start to build up in the blood. And we'll be able to recognize that by measuring your BUN, which is your blood urea nitrogen levels. We can also look at something called creatinine. Now, this is a waste product from muscles. It's created at a fairly regular rate and eliminated through the kidneys as well at a regular rate. And as a result, your creatinine level in the body should really stay pretty consistent. And so when we start to see an elevation in creatinine, it can be an indication that your kidneys are starting to not function quite normally. And so this is used as a really quick way to assess renal function. And it's approximated by taking your initial creatinine level and dividing it by your current creatinine level. And we'll see an example of that. So acute renal failure. So acute renal failure is going to be acute, so it's an abrupt onset. It is often reversible if it is recognized early and treated appropriately. So again, when you see something wrong happening all at once and you go get treated for it and take care of it, then the damage is going to be minimal or often reversible. So you're going to see a rapid decline in renal function, and that's why acute renal failure is typically recognized, because you see this rapid decline all at once, and so you know there's something wrong. And that decline is going to be sufficient enough to increase blood levels of nitrogenous waste, impair fluids and electrolyte balance, decrease your glomerular filtration rate, GFR, and as a result, you'll have excretion of nitrogenous waste being reduced, and fluid and electrolyte balance won't be maintained like normal. And your glomerular filtration rate is calculated with your age, race, gender, height, weight, and serum creatinine. And normal GFR is going to be greater than or equal to 90 milliliters per minute. Now, acute renal failure can happen for several reasons, or several things can kind of precipitate it. The first thing I want to talk about is pre-renal failure. So pre-renal, the word pre, we're going to use the kidneys as our main starting point. So pre would be before the kidneys. And what's before the kidneys is the blood coming into the kidney. So blood will come in through the renal arteries into the nephron, and then you do the filtering and the reabsorbing and all of that here. And then whatever remains in the nephron is going to go in through the renal pelvis and down your ureters, out into the bladder, and then out the urethra. And so we're moving in this direction here. So what is before our kidney is the blood coming in. So pre-renal failure is going to be caused by a decrease in renal blood supply. So in this case, the reason the kidneys can't do its job of maintaining body fluids, maintaining electrolytes, getting rid of waste, etc., would be because the kidneys aren't getting the blood supply to do all of that. So a decrease in renal blood supply, maybe because of shock or dehydration or vasoconstriction or an obstruction, over up here, not down here, but up here, could all be categorized as being pre-renal failure. Now, then we have intrinsic. I'm going to actually skip down here first. So intrinsic would be inside the kidneys. So inside the kidneys would be in, for example, the nephron. So when your kidney tubule function is decreased, or the kidney structure is damaged because of ischemia or toxins or some sort of intratubular obstruction. And that's why your kidneys can't do its job. Then we have intrinsic renal failure. And then we have post-renal. Post is after. So what is after the kidney is a tube that we're trying to send the urine out through. So if that's the issue, then we have post-renal failure. And typically that's because of a blockage, some sort of an obstruction that obstructs urine outflow. So maybe a kidney stone or a tumor or an enlarged prostate that compresses the ureters. Okay, so we have pre-renal, intrinsic, and post-renal failure. So a man developed acute renal failure after emergency surgery for a severed leg. So why would leg damage cause renal failure? Well, when you have leg damage, you're probably going to lose a lot of blood, as well as the trauma decreasing blood flow to the kidneys as we turn on the sympathetic nervous system with the GAS, and less blood going to the kidneys can also be a contributing factor to that. So would this be an example of pre-renal, post-renal, or intrinsic renal failure? So we're losing blood, we are vasoconstricting and decreasing blood supply to the kidney. So that all sounds like something happening before we even get to the kidney. So the best answer would be pre-renal failure. Now he came in with a serum creatinine level of 1.2 milligrams per deciliter, but now it's 5.6. So what that means is his creatinine level started to rise. And so it's starting to rise because we're not eliminating it from the body. So the kidneys aren't working quite normally. So what's his remaining kidney function, at least compared to when he initially came in? So if you remember, we said to look at kidney function, or a quick way to look at it is to take our initial and divide it by the current. So initial was 1.2, currently it's 5.6. So if we divide the two, it's 0.21. And to get a percentage, multiply it by 100, so about 21%. So that's what the kidneys are functioning at now compared to when he initially came in. Now his urine contains tubular cast cells. Now casts are formed when cells are packed together into tubules, and this occurs because the cells essentially died and started to break off, and they can block the tubules, and then eventually it washes out and starts to appear in your urine. So what does the presence of casts mean for the patient? It means there was probably tubular damage, and typically that occurs because of a lack of oxygen. So we had acute tubular necrosis happening here. So now let's talk about chronic renal failure. So chronic renal failure is the end result of irreparable damage to the kidney that develops slowly over years. So what you're going to see is reduced kidney function due to destruction of your renal nephrons and a marked decrease in your glomerular filtration rate. And the symptoms are not evident until the disease is advanced. And why is that? And remember we said the kidneys have a huge physiologic reserve. And so because of that, the kidneys are really good at compensating. And because of that, that's why it develops slowly over years, and you really are not aware that you are damaging the kidneys. So here's a quick example of that. So here we have a kidney that's made of just 1, 2, 3, 4, 5, 6, 7 nephrons. And when we have one nephron damaged, the other nephrons will actually just work harder. And we're going to see that with by seeing an increase in blood supply going to those nephrons. Now, what is causing the damage hasn't been dealt with. And so as a result, another nephron gets damaged. And so the other remaining nephrons just start to get hyperperfused. So they get more blood. And again, as they're working harder, they also start to hypertrophy. Now, because they are still able to work harder, you don't see any signs and symptoms yet. So it isn't until you've damaged a significant number of your nephrons or a significant portion of your kidneys that you start to see signs and symptoms, because now the remaining nephrons aren't able to keep up. So you have exhausted your physiologic reserve. And so this is why it's slow, it's progressive, and it happens over a long period of time. And the manifestations don't show up until you've done a lot of damage to the kidneys. So chronic renal failure has a lot of manifestations, and this is a figure from your book. It's a great kind of summary figure. So with chronic renal failure, just think about all of the normal functions of the kidneys, and you just won't be able to do those things. For example, when you have renal failure, you will no longer be able to balance your sodium and water. As a result, you will have hypertension. So if you can't eliminate sodium, and obviously we know water follows sodium, and you don't eliminate water like you normally should, then all of that remains in your blood, and so you get high blood pressure. And you also have increased vascular volume. And so all of that can contribute to edema and heart failure, because your heart now has a greater load it has to contract. You also won't be able to manage your potassium levels, and so you won't eliminate potassium like normal. It's going to stay in your blood more, and that leads to hyperkalemia. And we talked about how changes in potassium can change excitability. In this case, it's going to increase excitability. You also won't eliminate your nitrogenous waste like you normally should, which means all of that waste remains in your blood. So essentially, think of it as urine is staying in your blood, which leads to uremia. Emia, blood, urine. Okay, urine in the blood. So if you have urine in the blood, it's going, first of all, it's going to damage the things that are normally circulated in your blood, including your platelets and all of the other contributing factors that contribute to blood clotting. And so you'll have clotting issues or coagulopathies, leading to increased likelihood of bleeding. And blood goes everywhere. And so when you have urine in the blood, that toxic urine is going everywhere to your body, including to your heart, leading to pericarditis. It can also impair immune function because we have white blood cells in our blood. It can lead to skin disorders, GI issues, neurologic issues, sexual dysfunction. We also know that the kidneys make erythropoietin. So when the kidneys fail, it also won't produce erythropoietin like normal, so that can contribute to anemia. Also, the uremia can also contribute to the anemia as well, since red blood cells also circulate in the blood. We'll also have acid-base balance issues. Remember, the kidneys play a role in helping to regulate body pH. And so really, it's usually acids as opposed to bases we have to worry about. So because we can't deal with the acids, we can suffer from acidosis. The kidneys also play a role in activating vitamin D, and we know vitamin D has to do with absorption of calcium in the intestine. So we won't be able to absorb the calcium like normal, leading to hypocalcemia. And we know when we have hypocalcemia, we're going to release parathyroid hormone to try to elevate calcium, leading to hyperparathyroidism. And when we have a lot of parathyroid hormone, we know one of the ways we try to get calcium in the blood is by taking it from our taking it from our bones. And so it can lead to bone issues. So you can see how so many systems of the body are really going to be impacted because of kidney failure. Sorry. Okay, so how does chronic renal failure develop and what are the stages? So usually we have 4 stages. The first is diminished renal reserve. So our physiologic reserve of the kidney is our renal reserve. So we talked about how as you start to damage some of your nephrons, the others just work harder. They just start to call upon their renal reserve. So the first stage of renal failure is just that reserve getting smaller and smaller. So that's our diminished renal reserve, where the remaining nephrons are just working as hard as they can. At this stage, we really aren't going to see any signs and symptoms. Why? Because we're using the reserve. So the reserve is just making up for any lost nephron. So no signs and symptoms yet. Then we have renal insufficiency. So renal insufficiency is when the nephrons are now no longer able to regulate urine density. So now we're starting to see some consequences. Then we have renal failure, where the nephrons can no longer keep blood composition normal. And then we have end-stage renal disease. So this is where dialysis is needed, kidney transplant. And here we're really going to see your GFR, which normally was about 90 milliliters per minute, is down to 15 milliliters per minute. Obviously, with kidney failure, uremia, which we mentioned is, again, urine in the blood, is a consequence. And we see that a lot because the kidneys aren't going to eliminate it from the body. We'll also see renal filtering function decreased. So we'll have altered fluid, altered electrolyte balance. Again, all of this was seen in that summary figure. So we already talked about how acidosis can occur, hyperkalemia, salt wasting, hypertension, and we'll also see waste buildup in the blood. Again, that's the increased creatinine, which we use creatinine to look at kidney function, the BUN, which all of that urine in the blood can be toxic to whatever is in the blood, like red blood cells and platelets, white blood cells, and it's also toxic to whoever receives blood, so really including our nervous system. So that's why we had neurological issues as well as one of the consequences. And keep in mind, we're also not going to make erythropoietin like normal. We're not going to activate vitamin D like normal. So this is just, again, reiterating some of the consequences. So a man has chronic renal failure, and he has high creatinine and BUN. He also has hyperkalemia, acidosis, and he has a normal partial pressure of carbon dioxide. He also has severe anemia. So this is listed here, the normal partial pressure of CO2, to really let you know that his acidosis is not due to a respiratory issue. So he doesn't have respiratory acidosis, he has metabolic acidosis. His blood glucose has reached 340 milligrams per deciliter 1 hour after a hospital meal. He complains of having broken 2 toes in the last few weeks, even though he eats a lot of dairy for calcium. So that's a lot of information to ask a simple question: what caused his anemia? So we obviously know he has chronic renal failure, and one of the functions of the kidneys is to make erythropoietin. So the lack of erythropoietin would be one of the causes. The other is his high BUN. He has uremia. And remember, that's going to be toxic to the contents in the blood, including red blood cells. It's going to destroy the red blood cells, which will also contribute to the uremia. Now, why are his bones brittle even though he eats dairy products? Well, if he has renal failure, he's also going to fail to activate vitamin D. And without vitamin D, you're not going to absorb calcium in the intestines. Remember, you need activated vitamin D to absorb calcium in the small intestine. And so his calcium levels are going to be low in the blood. And when his calcium levels are low in the blood, his body will try to raise calcium by releasing parathyroid hormone. And one of the ways parathyroid hormone raises blood calcium is by mobilizing it from our bones. So it's going to break down our bones, and that's why his bones are brittle, even though he eats dairy products. Because the calcium in the dairy may not be getting into his blood like normal. Now, with chronic renal failure, we'll have other consequences as well, including the cardiovascular system. With less erythropoietin, we'll be anemic. With less red blood cells, we'll have lower blood viscosity. Blood will flow more swiftly through our blood vessels. Our heart rate will increase as a consequence of anemia. And that'll increase the workload on our left side of the heart, leading to hypertrophy. And our heart is working harder, but the oxygen supply may not be meeting the demand. That can lead to chest pain. We can have ischemic issues and left-sided heart failure if this progresses. Now, there are other parts of the body that are going to be affected because of chronic renal failure. So let's take a look at the mechanism by which we see these other consequences. So azotemia is just high nitrogen-containing compounds. So again, with chronic renal failure, we'll have a decrease in the ability to excrete our nitrogenous wastes, which means it remains in the blood. So we're going to increase our BUN, our blood urea nitrogen, and that's going to lead to the azotemia. Why do we get metabolic acidosis? Well, with chronic renal failure, we're going to decrease the ability to excrete our hydrogen ions, which means more of them stays in the blood, which is going to contribute to acidosis. And we can have decreased ability to reabsorb the bicarb, and bicarb was our good buffer, and so again, less buffers means more acids. Why can it lead to hypertension? Well, with chronic renal failure, we might increase our renin-angiotensin activity. So more renin angiotensin activity increasing because we have less blood going to our kidneys, that can increase our vascular volume and lead to hypertension. How can we get anemia? Well, with chronic renal failure, we have less erythropoietin being produced. So then we have fewer red blood cells being formed, and so we're anemic. Plus, the nitrogenous compounds can destroy the red blood cells. And then why do we have altered drug sensitivity? Well, with chronic renal failure, we're going to decrease the rate of drug excretion from the body. We might also have less plasma proteins for the drugs to bind to. And the uremia will also impact the drugs in our blood. So it can alter the metabolism of some of the drugs as well. I want to end with this YouTube video on artificial kidney transplant. So you're actually going to need to copy this into your browser, or I will, if I have time, show it in class. But this is just research that's going on that's quite interesting about an actual artificial kidney. So instead of needing a transplant from a donor, scientists are developing the first artificial kidney to be implanted into the body. It's a biohybrid approach that uses both living kidney cells as well as specialized microchips that's powered by the human heart to filter waste from the bloodstream. And the National Kidney Foundation estimates that over 100,000 patients are on the waiting list now for a kidney, and over 3,000 are added to the list every year. So, obviously, having another source other than waiting for a donor would be beneficial. The average patient spends about 3.6 years waiting for a viable transplant, and they may be treated with dialysis while they wait, but only 1 in 3 dialysis patients actually survives long enough, um, or longer than 5 years without a transplant. And, we really want to make sure that these patients don't have to wait. And the transplanted organs from deceased or living donors must be carefully matched in order to avoid tissue rejection, but an artificial solution could obviously bypass those complications as well. And so it's just a quite interesting clip about the development of this new technology. Thank you.